All right, it's just about time to get started. People that are online, go ahead and give me a thumbs up if you can hear me okay. Okay, cool. Then we got clicker. We got a clicker. All right. Well, thanks everyone for coming. So this month, our theme is cardiac arrest management. It's going to be split into two parts since there's kind of so much that we could talk about. So March and April will be cardiac arrest management, and then May, I'm calling back to basics. It's going to be like a BLS-oriented M&M for all of our BLS providers. So reminders, all of the registration for all of our M&M sessions is available at trinityhealthofne.org/EMS-classes. There's always a flyer up in the EMS room at Mercy with a QR code that goes to the same website. That website has all of them on there, and then the individual links that'll take you to register for each of them. We're also on social media where that stuff gets announced. Unfortunately, there are different accounts depending on which platform. TH of NE EMS on Instagram. We need more followers, so if you're on the gram, show us some love. And Trinity Health of NE EMS on Facebook. I'm working with our marketing department because, as you've probably noticed so far, kind of our new format is we do kind of like lecture for the first part, and then we go over cases the second part. I'm working with our marketing department to get the lecture portion posted on our YouTube channel. So for people that want to watch it later, obviously we can't include the case discussion, but if they want to watch the didactic part, that'll be available sooner rather than later. As you can imagine, there's a lot of people that have to sign off on that. All right, so for the participation, slightly different. If you're in person, definitely scan the QR code. As we go through the presentation, questions will pop up, and then the poll answers will show up here. Remote participants, do whatever is easiest for you. So if you're if you've got it up on a screen somewhere and you just want to respond on your phone, so if you're like at an apartment where a bunch of you are watching it together, go ahead and just scan it and participate. If you don't, like you're just sitting at your own computer, then the poll questions will show up in the chat, and then you can respond there. So let's start our first poll. Should be popping up there. How do you feel? Lots of 3s and 5s. I'll take a solid 3. Yeah. Okay, let me go back. Yeah. Okay. Oh, who's the one? Too bad. All right. Renee, we're seeing a similar distribution on the. Okay. Oh no, it's getting worse. I should move on to the next slide. Okay. So the last 2 months we've been talking about airway. So airway is part of cardiac arrest, but we're obviously not going to spend as much time on it. But there's a ton of stuff that we can talk about with cardiac arrest. So in this month, we're going to focus on CPR, airway management, and IV versus IO. Next month, we're going to talk about defibrillation, decision to transport, post-BROS management, and some of the like cutting-edge research stuff that's being done. So starting with CPR, what do you think is better? Mechanical CPR or manual CPR or same? Okay, I like that there's a little bit of disagreement. Similar on teams, Renee? Yep. Okay. Okay. Cool. So I want to talk about, there's a bunch of studies that have been done on this, but I'm going to talk about this one study that was done in Texas and then kind of summarize some of the other available research that's on it. In this particular system in Texas, they had a very effective, high-functioning pit crew-based CPR model. And they said, well, let's see what happens when we add the Lucas device. So they rolled out a bunch of training and choreography and everything to try and incorporate the Lucas into their pit crew-based CPR team approach. So they had an existing high-performance pit crew CPR program. They added this sort of carefully choreographed mechanical CPR, and they found that their ROSC decreased from 38.6% to 28.4%. And they also had decreased neurointact survival from 13.6% to 6.8%. Right? Kind of surprising. So, what is happening here? Yeah. Mm-hmm. Okay. Mm-hmm. Okay. So over reliance, it's better for extrication and transport than the actual code. Yeah. They they spend a lot of time training people so they could minimize the time to get the Lucas on correctly. It wasn't just like, here guys, just go ahead and use it. It was a carefully rolled out educational thing that went along with the intervention. So in the literature that's out there, this experience is not unusual. That when you implement mechanical CPR, that you actually see a decrease overall in ROSC and survival. In most of the research that's been done on this, the average time off the chest to get the Lucas applied is about 30 seconds, which is, as we know, way too long. There are different choreographies and studies that have been used where they can get that down to like 10 seconds. But it usually kind of has to be done in a few different steps rather than trying to do it all at once. But it does tend to be associated with longer pauses and decreased compression fraction. So the moral of the story seems to be that good team CPR is probably better than mechanical CPR, except for transport or extrication. So the Lucas is not magic. Yeah, question. Mm-hmm. It's been studied in in-hospital cardiac arrest, and it's even worse, probably because the patients in the hospital at baseline are sicker than they are in the community. Because correct, like you're already in the hospital, so you were already sicker to start with than someone who's in the community. So the main advantage to the Lucas is that it is most definitely, as you identified, the only safe way to transport a patient in cardiac arrest. Now that is operating under the assumption that you should be transporting a cardiac arrest at all, right? Which I would say in the vast majority of cases you shouldn't be. You should work for 20 minutes and then call us to call it. The edge cases, as we mentioned, prolonged extrication or resuscitation, and then patients that should be transported like hypothermic arrests because there's an intervention. Again, the patients that should be transported are the ones that there's something else we offer at the hospital. Like it's not like we're getting like higher, like better grade epi, right? You guys get all your drugs from us. We don't keep the good ones for us, right? It's like the epi doesn't work any better. The bicarb doesn't work any better. It's all the same. So unless there's something we're going to offer, right? Like hypothermia, right? They can put them on bypass. Pregnant patients can have resuscitative hysterotomy. A penetrating trauma, cardiac arrest, they can crack the chest. ECMO candidate, maybe in the future, if Baystate chooses to offer that, putting them on bypass for cardiac arrest. Now, one of the pieces of feedback that I've gotten in the last couple of months is like, well, it's great, all this ALS stuff, but what about us BLS providers? So I'm going to introduce a new recurring character to the Mercy M&M's BLS bill. So BLS bill is going to appear every time that I want to make a point about what the BLS providers can add to what I'm talking about. And so BLS providers, Applying the Lucas, the team-based CPR, that is very much in your wheelhouse. And this is something that you can practice and do and get excellent at so that you can offload your medic's brain about, I don't really have to worry about the choreography of getting the Lucas on because I can trust my basics to do that very quickly and very effectively. So for any of the basics that are watching this, this is something that medics, you need to know it too, but basics, this is something you can actually do and make a huge difference on with the patient, is being excellent at that choreography for getting the Lucas on with minimal pauses. And so to demonstrate that, I'm going to show this video. This is actually like a transition from an EMS Lucas to a hospital Lucas, but a lot of the same principles apply for putting it on for a patient that you just got to.
This scenario will demonstrate steps for transferring a patient in cardiac arrest from the field Lucas to an emergency department Lucas. Our goal for any transfer is to avoid interruptions in CPR. In this scenario, EMS will bring in a patient in cardiac arrest who is receiving chest compressions from the Lucas. The patient will be moved over, the Lucas will be removed, and ED providers will begin manual CPR. Eventually, the hospital Lucas will be placed and started. To transfer a patient in cardiac arrest from an EMS Lucas to a hospital Lucas, 4 things happen that require brief pauses in CPR. First, the patient is transferred from the EMS gurney to the ED stretcher. The EMS Lucas tower is removed, and manual CPR is started. Second, the anterior defibrillator pad is removed and replaced with a hospital defibrillator pad. Third, the patient is rolled to their side and the posterior pad, the Lucas backplate, and the EMS flat are removed. The hospital defibrillator pad and backplate are then placed. The patient is then rolled back down and manual CPR is resumed. Finally, the hospital Lucas tower is attached and started. If these steps are carefully coordinated and roles are assigned in advance, each can be accomplished with a pause in CPR of less than 10 seconds. The whole process can be completed within 90 seconds of the patient arriving in the trauma bay.
All right, team, let's huddle. We have a 65-year-old male in refractory defib arrest. He'll be here in 2 minutes. He's coming in on a Lucas.
Before the patient arrives, the code leader should let the team know whether or not to prepare for possible Lucas use. If you might use the Lucas, this is a good time to remind the team to defer interventions such as intubation, starting IVs, and drawing blood until after the Lucas swap is complete, and to assign roles to each team member involved in replacing the Lucas. We will break down the responsibilities of each person later in this video.
Can we go around and say our roles, please?
I'm Liz. I'll be on the right side and leading and applying the new Lucas.
Helen, airway. Kelsey, I'll be doing compressions. Claudia, backplate.
Sarah, I'll be patch. Great, let's get ready. They'll be here in 2 minutes.
Hold the EMS report until transfer is complete.
Ready for report?
Let's hold report until transfer is complete.
Step 1 is to transfer the patient over to the ED stretcher while the Lucas continues to provide compressions. When ready to take over CPR, ED providers will ask EMS to remove their Lucas tower, and the ED provider will start manual chest compressions.
Let's prepare patient for transfer. Down a little bit.
Lucas and
Let's start manual CPR. Let's lift the arms up.
And then hold on a second.
In a minute, I'm going to need help with turning the patient to somebody else.
Okay. And then I am ready whenever you want to take off the anterior pad.
Step 2 is to exchange the anterior EMS defibrillator pad for a hospital defibrillator pad. When everyone is ready, the compressor removes the EMS pad and the pad person replaces it with the hospital pad. This only takes a few seconds, so take the time to ensure the pad is positioned correctly on the midline and at the level of the patient's nipple line before placing it.
And then place.
Okay, are we ready with the back plate? We're ready with the pass?
Ready.
All right, I'll take the back plate.
The third step is the most complicated part of the process. When everyone is ready and the patient's arms have been lifted up above his head, the two providers on the patient's right will roll him. The compressor will remove the posterior defibrillator pad and the EMS backplate, stepping back and out of the way. The pad person will place the new pad, and the backplate person places the hospital backplate. The backplate person will now be in a good spot to take over compressions once the roll is complete. The other two providers and any assistants closer to the patient's feet remove the EMS flat and get out of the way so that the patient can be rolled back down and compressions can be resumed.
Patient 1, 2, and 3.
And place.
Okay, turn the patient back. 1, 2, and 3.
Okay, resume compression. Get the Lucas ready.
Now, putting all of the steps of the roll together, the compressor removes the EMS defib pad and backplate. The defib pad person places the new defib pad and helps remove the EMS flat. And the backplate person places the new backplate and then takes over manual CPR. Watch one more time. EMS flat slides out, posterior pad is attached, EMS Lucas plate out, hospital Lucas plate in, roll and resume compressions.
1, 2, and 3.
Okay, resume compression. Get the Lucas ready.
The final step is to attach and start the hospital Lucas.
Okay, we're ready. For the Lucas on the other side, you have the backboard ready. 1, 2, 3.
We're ready for report.
Okay, we have a 56-year-old male who's found at home on the living room floor in cardiac arrest.
Let's go over the key points one more time. Have a briefing before the patient arrives to assign Lucas roles. Please note that if hospitals and EMS providers have compatible equipment and prearranged agreements to swap backplates, steps 2 and 3 can be omitted, and it may be possible to exchange only the Lucas tower as part of this process. Hold IV access, blood draws, and the EMS report until after the ED Lucas is engaged. Resume manual CPR if there is a delay in applying or starting the Lucas. Our goal is to minimize interruptions in CPR and to keep all interruptions shorter than 10 seconds.
So you can see like they're putting a lot of effort, right, into doing this quickly. And so how applying that or doing it a little more, and I'm sure that every time you've ever seen a transition from an EMS to hospital Lucas, it is nowhere near that. Like that was like Dancing with the Stars choreography, like compared to, you know, that breakdancing chick at the Olympics, like, which is what it usually is. So, next question. What's the ideal compression ratio, do you think, for all patients, or, you know, depends on the airway? Is more compressions better compressions? 30-2. Depends on the airway, you know, per ACLS. So most people think Mo compressions is better compressions. Okay, so I have always thought that it's a matter of compression ratios, right? Weight ratios, Monty Python reference for any other fans out there. Because the coronary perfusion pressure drops during pauses, and you have to like, you got to prime the pump again, right? Take that pressure back. So obviously, more compressions is better compressions. So traditionally, I have erred on the side of doing continuous compressions. And you probably see in the hospital, even when we don't have an advanced airway in place, they're still like trying to bag through doing CPR, right? And in fact, that's kind of what the state protocol advises, which I find hilarious because it says follow AHA ILCOR recommendations and then immediately tells you to contradict that. So, because AHA ILCOR recommendations would be 30 to 2, and then it's like, oh, like try to bag during recoil. Like, so this study, they looked at the ROC, one of the ROC trials, Resuscitation Outcomes Consortium, and they were looking at the original study was looking at continuous compressions versus 30 to 2. And so they were looking at, okay, what if there is actually a difference between all 30 to 2 and good 30 to 2 and bad 30 to 2, okay? So what if there's actually 3 groups? And if you lump people that do 30 to 2 with good ventilation and people 30 to 2 with bad ventilation, if you put those together, by the way, so the original study, 30 to 2 versus continuous, they found no difference, okay? But what if you take out the people that got bad ventilations? Is there a difference? So that's kind of what they were looking at here. And somewhat surprisingly, they found that there was a dramatically higher, there was dramatic improvements in good 32 with bad 32. Oh, that is not what I wanted to do. There we go. This is what I wanted to do. So on the good 32, so it's got like 40.7% ROS, 0.7% ROS with good 32 versus 25 with bad 32. Now, in the study that they were comparing the good versus the bad ventilation, they were not comparing good versus continuous, but I'm putting it up here because that's from the same research trial. That's just not what they were addressing in this study. Yeah. That appears what they found is that 30 to 2 with good ventilations across the board is better than 30 to 2 with bad ventilations or just straight up continuous and trying to do like the chest recoil thing. So the ventilations appear to actually be important despite that we've switched to CAB and everything. So I have somewhat changed my thought process on this, and that is that good 30 to 2 is probably better than just doing continuous. If you're going to do bad 30 to 2, then you can just do continuous or whatever. But if you can make the 30 to 2 with good ventilations work, that appears to be better. Yes. Mm-hmm. Yeah, I'm not sure though, because the continuous people had the advanced airways in, and in other studies where we looked at are there any differences in advanced airways, we haven't found one. But maybe because no one's looked at this exact question, right? Because we always looked at all non-invasive, all BLS airways versus all ALS airways, right? And so maybe good BVM versus continuous with an endotracheal tube is different from good VVM with an LMA. We don't know. No one studied that. Yes. So good questions. I am not sure off the top of my head in the ROC study. I believe the ROC study was all BLS airways in the actual study. So it was BLS continuous versus BLS 30 to 2. Should you be using the Lucas in the 30 to 2 mode? Well, the question is, should you be using the Lucas at all? Number one. Okay. And number two, if you are, I think I kind of would, based off of this study. And there's not again, like technically The state protocol says follow AHA, but I don't think it's a bad thing to be doing 32 versus continuous on there. Other question? Okay. Mm-hmm. Yeah.
ALS provider for obviously doing the other stuff, and
Yep.
typically it's a BLS provider for
Mm-hmm.
the airway stuff. How do you suggest approaching that if you can't take over during that time?
Okay, so how do we coach the BLS provider in improving their BVM? So I think number one, because even though this is a typical scenario for us, it's still a little higher stress than the normal belly pain, chest pain, or whatever. So I think when I'm coaching people in an arrest, number one, I think is to be direct without being, necessarily rude, but I'd say, Bob, BLS Bob, right? Hey, Bob, it looks like you're having trouble with your mask seal. Do you think you can get someone to help you so that you can use two hands on the mask seal? Or, hey, Bob, it looks like you're really, you don't need to go plastic to plastic on that bag, just enough for chest rise, please, and thank you. Okay, so just be very direct with the feedback. And also, this is something I've made a habit of, is actually saying please and thank you during arrests. And also, this is another thing that actually helps with closed loop communication. So for example, when someone calls out a blood pressure, like they're like, oh, the blood pressure is 120/80. And I'll say 120/80, thank you. So they know that I've heard it, and that was also nice. Okay, so right, it kind of brings everyone's tone down. And so that's something I've found successful in resuscitations and trying to coach people. Does that help? Good. Okay. So CPR summary. We don't know what the best role for mechanical CPR is, other than if you're transporting, definitely, because that's the only safe way to do it. Because I know you're not going to do it, but I want you belted in the back. And good 30-2 is probably better than continuous CPR. So let's move on to the airway discussion for the morning. What is your cardiac arrest airway strategy? BVM all day, every day? SGA all day, every day? ETI or bust? Or tube and supraglottic if I can't get it? Similar online, Renee? Okay. So less love for the BVM on the online group. All right, well, there are a few studies that have looked at this. There's the Airways 2 trial, which looked at iGel versus endotracheal tube, found no difference. King LT versus endotracheal tube found that King was actually slightly better. And then another study that looked at King versus iGel, which showed iGel improved ROSC and neuro intact survival over the King. So this is hard because you've got all of these things that have been compared to each other. And so it's hard to compare it, like if A is greater than B and B is greater than C, is C greater than A? Like kind of thing. Yes. Yeah. Right. And we'll get to what the National Association of EMS Physicians recommends based off of the available research. Which is the NAEMSP position statement and research document on pre-hospital cardiac arrest airway management. And they have 4 kind of sweeping guidelines that come out of this. And it's pretty much exactly what you say. Based on the skill of the clinician and the available resources, BVM, supraglottic, or endotracheal tube may be considered. Airway management should not interfere with other key resuscitation interventions, such as high-quality CPR, defibrillation, et cetera. Clinicians should avoid hyperventilation, and when available, use capnography. So it's use what you have and you're comfortable with and you're good at, right? Because again, all the research appears to be, it's kind of a wash. So do what you have and do what you're good at. Be sure you get it the first time. Don't stop compressions and use waveform capnography. Personally, at the hospital, I'm throwing in an eye gel. And later on the line, if I get Ross, then it'll get switched out. So again, BLS Bob has entered the chat, which means like if you're on a cardiac arrest and if you're a BLS, you can manage the airway. Okay, an OPA with good BVM and mass seal is just as good as everything else. There is not a reason to necessarily have to use an advanced airway. If you're a EMT with the ability to do a supraglottic, great, you can do that. It's not better or worse than dropping a tube. So let's talk about IV versus IO. What's the best route for meds? IV, IO, or first available? Okay. Are we looking online, Renee? Okay. Not dissimilar to here. So there's a bunch of papers that have looked at this, IV versus IO, and the current AHA guidance is that IV would be preferred. Like it's worth attempting an IV before you jump to IO. For a while, it was IO first because it's faster, has a higher success rate. Remember that all of this is predicated on the assumption that the drugs you're giving are going to make a difference, which we still have not really proven, okay? So this study, which you might know, whoops, wrong one again. You might know one of the people involved. We were looking at upper versus lower extremity IO, okay? And so, because everyone's like, oh, the upper one's better, right? And so what we found in this study was that upper versus lower, there's a very, 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 very small benefit to upper versus lower, which probably means that there isn't a real difference, and we were just using a database with several million patients in it, so you can detect these really small differences that are not practically important. So upper versus lower, there's probably no difference. IV versus IO, there's probably no difference. And like I said, this all assumes that the drugs have benefit to begin with. So do what you're comfortable with. If you have enough people on scene that someone can try an IV first, do that. If you have limited resources and the fastest thing is for you to drill the patient and move on to the next thing, do that. Okay? They all seem to be roughly equivocal, and that's so do what's best for the situation in front of you, is what I'm getting at. All right, some bonus content talking about ROSC, terminated resuscitation, pulse checks, and trauma. So I want to bring up the termination resuscitation protocol. I feel like this is probably underutilized. Some things I want to point out in terms of the requirements. So no hypothermia. It says indicated ALS has been undertaken. The patient is persistent PEA or asystole, persistently for 20 minutes, no reversible causes, not pregnant, because again, we can do a resuscitative hysterotomy at the hospital, and then you get a MedCon order. So things to point out. It says effective airway support, not advanced airway, which means BVM is okay. You do not have to have a tube. You do not have to have an LMA in place. If you've been running this arrest for 20, 30 minutes by bagging the patient, you can still call to terminate. Secondly, 20 minutes of resuscitative efforts, not 20 minutes of ACLS. So that's not 20 minutes from your first epi, that's 20 minutes from when you start the resuscitation, okay? So this you're probably thinking like, wow, there's a lot of things I got there, and by the time I was like ready to go, we were at 20 minutes and I could have called. And that's what I'm getting at, is that I think some assumptions have snuck in about advanced airway and the need for the drugs. Yes. Mm-hmm. Mm-hmm. Correct. Yeah, yes. So it says, so it says, and standard life support measures have been undertaken. So notice that these are different requirements, right? So it says indicated has been undertaken. Patient is in PE anasystole unresponsive to resuscitative efforts. So resuscitative efforts is separate from ALS measures. Correct. It all has to be present, but I would say that the clock starts from when BLS starts. So it doesn't say 20 minutes of ALS, right? But you can still, you should still try. Well, if you're getting to a third shock, you may end up needing to transport the patient. But if you're a couple rounds of epi in, you've been running this for 30 minutes, 30 minutes, not 3 minutes, 30 minutes. They're getting to there. By the time you get there, it's 2 no shock advised. You get there, third one's PEA, right? Like you're coming up on a time to call for, especially by the time you actually get us on the phone. Like you're going to be past 20 minutes. So another changing point. We are all awful at feeling pulses during cardiac arrest. One of my favorite studies, they took a bunch of paramedics, nurses, EMTs. They took them to the OR where they had patients on cardiopulmonary bypass. Okay, no pulse. Didn't tell them. They said, please do a pulse check. How long do you think, and take as long as you want, okay? In order for people to be confident that they were or were not feeling a pulse. They also didn't tell them what phase of the surgery they were in, whether the patient had pulses or not, okay? So how long do you think they took on average to be confident in their determination of pulse, no pulse? 30 seconds, anyone else, any other guesses? They lied. 30 seconds, right? How long is our pulse check, rhythm check supposed to be? 10 seconds. That's a wee bit longer, okay? What do you think their accuracy was? 15%. Well, it's 50-50. Basically, they could have tossed a coin, okay? So we're pretty awful at determining whether the patient has a pulse or not. So showing this video, this is a ultrasound clip that I took during a cardiac arrest. This is the femoral artery, and this is the femoral vein, right? The artery is stiffer and doesn't get compressed as easily, and the vein is thinner. So where do you think you're actually going to feel the pulse on here? The vein, okay? So when you're feeling pulses during an arrest, you're not even feeling them over the artery. You're feeling backflow from the veins for the most part. So since at least the 2020 update, if not I believe the 2015 update for ACLS, they have not called them pulse checks. They've called them rhythm checks, okay? So the whole like, oh, fingers on pulses, blah, 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 do you feel anything? No, just stop. If it's VFib, move on. Like, it's like, well, I don't think I have a pulse. No kidding, it's VFib, right? This is only relevant if you have an organized rhythm. A word on trauma. So, joint position statement between, this is American College of Surgeons and NAEMSP about priorities during traumatic arrest management. So, number one, they recommend the prompt identification of patients who may benefit from transport, okay? So, like that guy where someone can do the airway over here and they got to do the compressions over here, he's not going to benefit from transport, okay? The guy who was shot in the chest and was talking to you and then lost pulses in front of you, he would benefit from transport. Timely use of clinically indicated life-saving interventions, which include hemorrhage control, so tourniquets, direct pressure, etc., airway management in the least invasive manner, chest decompression, and external chest compressions may be considered, but only secondary to other life-saving interventions, right? So why do trauma patients die? They bleed out. What else? I'll give you a hint. It's the bullet points they highlighted, right? They bleed out, their airway doesn't get managed, or they develop tension, right? This is very different from the guy with coronary artery disease who drops and collapses and has VF or VFib, right? These folks tend to have PEA or asystolic arrests that when you fix the reversible cause, they get better. Versus the guy with the VF VT arrest, he needs defibrillation and chest compressions to keep things going. This guy, the chest compressions are secondary to fixing the problem. And epinephrine should not be routinely used or should not be administered before other life-saving interventions, right? So if they arrest because of trauma, epi is not going to save them, right? Because the point of epi is to increase the vascular tone for while we're doing CPR to perfuse the brain and save the brain. And if we're saying that CPR is not the life-saving intervention, that we're going to focus on fixing the problem, then the epi doesn't make sense. So work on airway management, hemorrhage control, and needling the chest if necessary. And then you can focus on the chest compressions. But that stuff actually needs to take a priority, right? Because if you think about your ABCs, you need to think about stuff that's interfering with the ABCs as you're going through it. Yes. That is what ATLS would tell you. Right. But, and, you know, luckily the state protocol does differentiate that. We'll get to the state protocol in just a minute because there is a separate traumatic arrest protocol. And also placement of cardiac monitor or ultrasound should occur also at the end. So all of the stuff that we think about as being the most important in a cardiac arrest, CPR, monitor, shocking, epi, is actually very secondary because we in a medical cardiac arrest, we prioritize the chest compressions, shocks, epi, and then we think about reversible causes afterward, right? I'm saying that for a traumatic cardiac arrest, we need to kind of flip that thinking, right? We need to work on the reversible causes first, and then we can, you know, worry about the other ACLS stuff because an ACLS medical arrest patient is very different from a traumatic arrest patient. So looking at the state traumatic arrest protocol, it outlines a lot of the same stuff, sort of at the first responder BLS level. But I don't think that the sequence here is necessarily in stone. So it talks about direct pressure, tourniquet, AED, whatever. I don't think that the order is important. It says early AED use. It doesn't say prioritize AED use, right? Sure, epi, when you get to that protocol, like, sure, you can use epi, right? For now, this is another holdover from prior protocols that apparently has not been updated. It says, for medication facilitated intubation, treat per protocol difficult airway. Absolutely not. That's not a thing anymore, right? I will not give you orders for 200 fentanyl and 10 of Versed to just YOLO and try and tube this person. Okay. Needs to be done properly with paralytics in a controlled setting. But this is outlining a lot of the same things, right? And all the stuff is here. It just doesn't really specify the order. And I'm saying that that gives you the leeway to do what's right for the patient, which is work on the reversible causes first. All right. Let's move into some cases.